Hi, so I'm Dan Rogers, as you know, one of the gastroenterology consultants, and today we're going to talk about ulcerative colitis. A lot of what we're going to say today is applicable to Crohn's disease as well, but to cover both of these conditions in one talk would just make it really too much of a marathon. So we'll talk off to begin with a little bit about what ulcerative colitis is, and this is, as you'll know from phase 1, a condition that's characterised by diffuse inflammation of the colonic mucosa. It affects the rectum and extends proximally different amounts, and this is important when you're thinking about staging the condition and also the different treatments that you might want to use. So it could be very distal, just affecting the rectum, and this is termed proctitis, or it may be more extensive, affecting the left side of the colon, inflammation up to the splenic flexure, or it could be more extensive, where it's going beyond the splenic flexure, or even pancolitis, where it affects the whole of the colon. In a small number of patients, it's impossible to distinguish between ulcerative colitis and isolated colonic Crohn's, and these patients are termed as having indeterminate colitis. Usually over time it becomes apparent which they've got, and either they develop some small bowel disease or the histological changes become more apparent as time goes on. So again, thinking back to phase 1, and I remember this table being presented to me when I was an undergraduate, and working out if someone with inflammatory bowel disease has got ulcerative colitis or Crohn's, and as we've said, usually it's fairly easy to work out. So Crohn's can affect anywhere from the mouth right the way through to the anus, whereas ulcerative colitis always starts in the rectum and progresses continuously and varying amounts throughout the colon. Whereas Crohn's disease has skip lesions, where there's this normal bowel, followed by abnormal bowel, followed by normal bowel, and then abnormal bowel again. At a histological level, in Crohn's disease, you're looking at transmural inflammation. So this is inflammation going across all layers of the bowel lining. And you can imagine why in patients with Crohn's disease, they can get fistulas if they've got two sections of bowel up against each other, both of those linings having transmural inflammation. In ulcerative colitis, the inflammation is limited to the mucosa and the submucosa only. Other histological changes, you think in fissuring ulcers, lymphoid and neutrophil aggregates, and non-caseating granulomas in Crohn's, and you're looking at crypt abscesses in ulcerative colitis. Now, the non-caseating granulomas is important as there are other conditions that cause granulomas, and particularly tuberculosis, although these would be caseating. And we do see tuberculosis affecting the bowel, and clearly the treatment of Crohn's is very, very different to the treatment of tuberculosis, and it's important that we do differentiate carefully between those two conditions. Crohn's disease is more common in smokers, and certainly those patients with Crohn's who smoke tend to have more severe disease as well, whereas actually ulcerative colitis has a decreased incidence in smokers, and actually you may sometimes see it first presenting a few weeks or months after someone stopped smoking. And it's not uncommon then that patients will ask us if they start smoking again, will this make their colitis better? The answer to that, of course, is probably yes, but it will cause other problems in the longer term as well. And it's probably the bad things in cigarettes that decrease the risk in ulcerative colitis. So what does it look like when we're looking at this down the camera? So the one on the right is a fairly dramatic picture, and this is just inside someone's rectum, and we can see here this is very inflamed, angry, sluffy mucosa, looking a bit more normal into salmon pink mucosa as we're going higher up there. And you can imagine why this patient is going to the toilet multiple times per day, why they're bleeding, and why they're really having to dash to the toilet when they're going. The picture on the left is actually in someone's small bowel, and this is a lot more subtle findings. And this is tiny little aphthous ulcers that you can see here, here, and here. And this could give them just as much dramatic symptoms as that appearance on the right hand side, because this small amount of inflammation could be affecting a section of the bowel that's vital for absorption of certain constituents of the diet, and therefore get quite significant diarrhoea from that. It's also important to recognise that patients' symptoms don't always tally with what the endoscopic appearance is like. You could have a really horrendous looking bowel endoscopically with fairly minimal symptoms, and equally someone who's got absolutely terrible symptoms but not an awful lot to find endoscopically. When we then think about what ulcerative colitis looks like radiologically, this is a plain abdominal x-ray, and we don't see them so very much these days, as lots of patients will get CT scans for most indications rather than abdominal x-rays. But I think in colitis they do still have a role to play, and we can tell lots of things from this x-ray. So just to orientate you, rectum's down here. We normally expect the sigmoid descending, transverse across the top, and the ascending colon coming down here. Obviously we've got spine in the middle and the pelvis and your hips at the bottom of the X-ray here. In the same way as with chest radiography, air is black. So normally we'd expect to see some solid stool in the left colon, and that's because the colon makes your stool more solid as it comes through, ready to come out. But in this patient, we can't see that at all. What we can see is a fairly raggedy looking left colon with a fairly featureless appearance to it. And you get these little indents here, which is where you can imagine that someone's pressed their thumb along the mucosa, and that's called thumbprinting. If we look along the transverse colon here, we can see this thick white line running along the lining of the bowel, and that's mucosal edema. You'll remember from your days of dissection that the lining of the bowel is tissue paper thin, so you shouldn't be able to see that on an X-ray. But when it's inflamed, edematous, you can. And so in this X-ray, I can tell you that this person's got a colitic process happening, and I can also give you an idea of the extent. So we know that this is happening throughout the left colon, into the ascending colon, which here is actually dipped down into this patient's pelvis as it's inflamed and angry. So this person's got almost pancolitis. So why are we talking about ulcerative colitis? Well, it's a common condition, an incidence of 10 to 20 per 100,000 per year, with a prevalence of 100 to 200 per 100,000. And so whatever area of medicine you end up working in, you will see patients with inflammatory bowel disease. It tends to present in young adults, but there is then a second peak later in life, and so we do occasionally get to diagnose ulcerative colitis in people in their 60s, 70s and beyond. And at that age, when patients are presenting with diarrhoea and bleeding, everybody, the patient and the doctors, expect to find a bowel cancer. So it can be quite a nice diagnosis to give patients who are expecting much worse news than that. There's a general consensus that it's a response to an environmental trigger in a genetically susceptible individual. So it's not a case of if you have the gene, you will get the condition. It's if you have the gene and something else happens, then you might get the condition. And it's not inherited directly, but there is clusters within families, and certainly with patients, if you take a family history, we'll find about 10 to 20% of them will have a family history of inflammatory bowel disease. As we've said already, smoking decreases the risk of ulcerative colitis, and it's important for us to recognise and remember that up to 50% of relapses of colitis are actually associated with gastroenteritis due to recognised pathogens, and that may be that this is someone who's actually got an infective colitis, or it's that there is an infection triggering off a flare of their ulcerative colitis as well. So how do we diagnose it? Well, as with everything in medicine, we need a combination of history, an examination, and then some investigations. Now in ulcerative colitis, there's less things on examination that are going to be helpful, and the investigations largely are endoscopic and radiological appearances taken together with the histology and microbiology. The cardinal symptoms that you'd be expecting to find in patients with ulcerative colitis are bloody diarrhoea, and this will include nocturnal symptoms. And that's not, going to the toilet last thing at night or first thing in the morning. That's actually waking from sleep overnight to need to open your bowels. And you can imagine that waking from a deep sleep, that's quite a significant symptom to be having. And so I always split my history into the number of bowel movements that people are having during the day and the number that are having overnight. And often you'll see those nocturnal symptoms start to settle before the daytime symptoms when patients are starting to get better. And again, during the day, if you've been having really bad diarrhoea, the second you start to think you're going to go, you'll still go. So you may not pass very much, but those nocturnal symptoms settling is often a good early sign that things are getting better. So the other symptoms that we'd see are urgency and tenesmus. So urgency is having to stop what you're doing and dashing to the toilet, or wondering where the nearest toilet is at all times. And patients will tell you that they maybe don't dare leave the house because they're getting seconds of warning of needing to go to the toilet. And when they tell you that they've got urgency, always then go on and ask about incontinence as well. And you'd be surprised how many of these patients during a flare are having episodes of incontinence. And that's a symptom that they really don't like to admit to, so there's quite a relief when they're asked about it directly. You can imagine when you're going back to that previous endoscopic picture of the proctitis and why patients might have tenesmus, that bowel's inflamed, stretched. The bowel can't tell that it's stretched from inflammation. It thinks it's stretched because there's something sitting inside it, i.e. a stool, wanting to come out. and not really knowing whether you do need to go to the toilet or not is a really quite disturbing and disruptive symptom. So how do we assess the severity of it? Now, this is something called the Truelove and Witt scale, and you don't need to remember this because I'm not going to ask you specifics on this in exams ever, but it's just to give you an idea that you don't actually have to be going to the toilet that many times to have a severe flare of inflammatory bowel disease. So a mild flare-up of IBD is less than 4 stools a day and no systemic features. Moderate, 4 to 6 stools a day with some minimal systemic disturbance, so maybe just a little bit of tummy pain or slightly tachycardic. Severe is over 6 stools a day with blood and with systemic disturbance, so a bit tachycardic, a bit of tummy pain, and just generally feeling not quite right, or a low-grade fever. So again, not actually going very many times before you're being classed as a severe flare, and severe flares of inflammatory bowel disease need to be managed as an inpatient, not in the patient's own home. So how do we investigate patients presenting with symptoms that could be consistent with inflammatory bowel disease? Well, I want to try and break this down, and I'd encourage you to use this sort of approach whatever conditions you're seeing patients. So think about simple blood tests first of all, then slightly more complicated bedside tests, then any imaging, and then any special investigation. So we can all say that we're going to check a full blood count, a CRP and a U&E on all of our patients coming in, but in your exams you're not going to get a mark for just writing down a blood test. And also in the real world, you want to be thinking, actually, why am I checking those blood tests? How are they going to be helpful in differentiating what's going on in this patient in front of me? So, full blood count. Well, this patient's bleeding, they're having bloody diarrhoea. Have they become anemic with that? Because that might be something we need to tackle. Have they got raised white cell count? Now that could be indicative of inflammation or infection. And what's their platelet count? And we see a number of patients who may have a normal CRP, which is your other inflammatory marker, but have got quite marked raised platelets. And patients seem to either be a CRP type of inflammation or a platelet kind of inflammation. And they can all point towards there being something going on. Again, use knees. And well, this patient might have been going to the toilet 20 times a day, so they may be a bit dehydrated, and they may be hypokalemic from all of their diarrhoea as well. And again, both of those are things that you're going to need to intervene on. We've already talked about a number of relapses being related to gut pathogens, and actually an infective colitis will present and look endoscopically exactly like inflammatory bowel disease. So we need to be sending off stool cultures, microscopy, culture and sensitivity, C. diff toxin, and now oocysts and parasites and entamoeba, serology and stool PCR. Then thinking about radiological tests, well, we've talked a little bit about x-rays already. Our main reason for doing x-rays in inflammatory bowel disease, if we think someone's got toxic megacolon, because that's a surgical emergency, that's not going to get better with medical therapy. But we've already seen a little bit that we can assess the extent of their inflammatory bowel disease with that evidence of inflamed mucosa or absence of any solid stool in inflamed ulcerated colon. How about proximal constipation? This can be quite an important thing to see. Now, you won't hear about this very much in the textbooks, but in patients who've got active left-sided disease, they can often become constipated above it. And you can think of it that through that inflamed section, the stool will move through there very quickly because it doesn't want to, the bowel doesn't want it touching that inflamed, sore, angry stool. But it then holds stool back above it to kind of try and protect itself. But actually, it's counterproductive because when you've got proximal constipation, your left-sided colitis will be worse. And you actually need to relieve that proximal constipation and to help induce remission in left-sided disease. So even though that patient may be going a number of times to the toilet, they may not be emptying out properly, and you may need to give them laxatives. So then more invasive, or hopefully the investigations are hopefully going to clinch the diagnosis. So in acute inflammatory bowel disease or acute ulcerative colitis, we'll be looking at a flexible sigmoidoscopy, just looking at the left-hand side. This is a safer than a full colonoscopy, less likely to cause perforation, and we also want to get a biopsy. Now, if things look really inflamed, we will just look in the rectum and not really go any further, because we know that in ulcerative colitis, the rectum is always involved. And therefore, we don't actually have to go any further in order to get the diagnosis if we think that going on further will cause perforation. At a later date, we want to do a full colonoscopy, both to formally determine the proximal extent and also to think about screening for any cancers that may be developing, as we know that ulcerative colitis increases the risk of bowel cancer. And we tend to start surveillance colonoscopy 10 years after diagnosis. So there's a few more things to think about with inflammatory bowel disease, these extra-intestinal manifestations, and these may be some of the things that you could see on examination or certainly be asking about in your history. And they split into 3 categories: those that are related to disease activity, i.e. these are present when the bowels are bad, those usually related to disease activity, and those completely unrelated to disease activity. So first off, if we think about those that are related to disease activity, so erythema nodosum, these are red, blotchy, almost bruise-like appearances, often on the shins. You don't see them very often, but when they are there, they're very pathognomic to tell us that there is something inflammatory going on. And so in the right setting, with a good history to suggest inflammatory bowel disease and the presence of erythema nodosum on examination, you could be really quite confident in saying that this patient is very likely to have inflammatory bowel disease, even before you've done any tests at all. Now, aphthous ulcers I find a bit more difficult, because this is, mouth ulcers and such like. This is, and these are common when you're unwell. If you have a cough or a cold, or you run down, you'll tend to get some mouth ulcers. So I think it's a bit more difficult to say they're definitely related to the inflammatory bowel disease, or is it more of a case that they're just unwell and therefore likely to get these things. Episcleritis colitis is one form of red eye and needs to be diagnosed by the ophthalmologist. And acute arthropathy, this is an inflammatory arthropathy, a bit like rheumatoid arthritis, that's particularly pain and stiffness that then get better with activity. And again, this is quite common, and it tends to get better when the bowels get better. Those conditions that are usually related to disease activity are pyoderma gangrenosum and anterior uveitis. So anterior uveitis is the other form of red eye, and again needs to be diagnosed with slit lamp examination through the ophthalmologist. Pyoderma gangrenosum is a really nasty ulcerative skin condition, and that thankfully is quite rare, but it can happen anywhere, and it can even happen in surgical wounds following an operation that's removed your inflammatory bowel disease. The bottom 3 conditions are all unrelated to disease activity, i.e. they can present before you've got a diagnosis of inflammatory bowel disease, when your bowels are quite quiescent, or even after you've had curative surgery. And these are sacroiliitis. This is inflammation of the sacroiliac joint, giving you pain and stiffness in the back. And we see a number of patients that have this condition diagnosed by the rheumatologists who have a little bit of bowel disturbance that's always been put down to irritable bowel. They get referred across to us, and they're found to have inflammatory bowel disease almost always. Ankylosing spondylitis is this gradually progressive stiffness of the back. You get this bamboo spine, sort of a question mark appearance, and when you're looking at patients side on. Primary sclerosing cholangitis, you'll have heard more about from Dr. Delahook. This is this beaded appearance to the bile ducts. The importance of recognising this is that this massively increases your risk of bowel cancer. And so if you have primary sclerosing cholangitis and ulcerative colitis, you should be having yearly colonoscopy from the time of diagnosis. And even then, you could still develop a bowel cancer in between that quite short surveillance interval. So as with all treatment of conditions, there are medical treatments and surgical treatments, and you're doing your medicine block at the moment, so we're going to focus on the medical treatments of ulcerative colitis and just touch briefly on the surgical management. So our aims of treatment are to induce remission in acute disease, to maintain that remission, to improve our patients' quality of life, i.e. let them get out and about, let them get on with their lives, not worrying where the nearest toilet is, and to decrease the risk of colorectal cancer in the long term. So before we come on to specifics of treatment of inflammatory bowel disease, we know that IBD is a very prothrombotic state, and we do have patients that develop DVTs and pulmonary emboli as a consequence of their IBD flare. So all patients in hospital with a flare of inflammatory bowel disease should be on low molecular weight heparin. It doesn't increase the amount of bleeding that they're having from their colitis, and there is some evidence that heparin can help treat the colitis due to microvascular occlusion happening in the colonic vascular bed. Now, to give you an idea of just how prothrombotic these patients are, we do have patients who are on, mobile, have TED stockings, and are on low molecular weight heparin, and still go on and develop DVTs and PE. I've got a young chap who developed bilateral DVTs affecting the whole length of his leg despite being on the appropriate antithrombotic treatment. And thankfully, it's a long time since we've had this happen, but we have in the past had a patient die from a pulmonary emboli due to their inflammatory bowel disease, and that patient again was young, mobile, had TED stockings and was on heparin. So they are really very, very prothrombotics. This is a really important medication to give. So in terms of inducing remission, steroids are our mainstay of treatment here. They've got no role at all in maintenance therapy, but they get people better quickly. There's lots of different routes in which we can give them, and this goes back to knowing the extent of the disease. So if this is very distal disease, so proctitis, we can actually give steroid suppositories. If it's left-sided, to go a bit further, we can give steroid enemas. And if it's going further, or patients really not getting on with those rectal treatments, we can give oral treatment with prednisolone. And if they're particularly bad and in hospital, we give intravenous hydrocortisone. Now, IBD itself is a risk factor for osteoporosis, and if you're giving steroids, you're multiplying up this risk factor. So you need to remember to give bone protection. In young patients, we give them some calcium and vitamin D, and in patients over 60, they'd be given bisphosphonates whilst they're on steroid treatment. Now, the dose of steroids needs to be weaned gradually over a number of weeks. This is a very different treatment course to things like COPD or asthma, where you just give a short, sharp 5-day course of steroids. We give him 40 milligrams of prednisolone for 2 weeks, and then we'll wean it by 5 milligrams a week. So they're on it for quite a number of weeks in total in order to get them better. If you use short courses or you wean them too quickly, then they will just flare up again. Now, as we've said, steroids have got no role in the long-term treatment, so we need other medications, and the 5 ASAs or mesalazine medication is our first-line treatment here. Now, mesalazine in its free form is actually rapidly absorbed from the jejunum, and so the drug has to be delivered to the colonic mucosa in one of several ways, as it actually works directly on the mucosa. It doesn't give a systemic body effect, it's actually working on the mucosa itself. So again, we've got topical preparations that can be given rectally, so suppositories and enemas. And the oral preparations can have various pharmacological modifications to get them to the colon intact. So things like Pentasa and Azecol, which are brand names, have pH-sensitive resins or membranes, and that start to break down in the distal small bowel, releasing the free drug into the colon. Or other things like oxalazine and sulfasalazine are linked to other molecules that are enzymatically cleaved by colonic bacteria, again releasing the free active drug in the colon. The main role of these medications is in the maintenance of remission, but you can escalate up the dose to treat mild flares and as a way of avoiding steroids, and patients can do that themselves without needing the doctors to tell them. Overall, they're said to decrease the relapse rate by 2/3 compared to placebo. They also decrease your risk of colorectal cancer, and it does seem to be that they decrease it over and above their effect of keeping you in remission. It's said to be a 75% decreased risk, but I don't really know how they've come to that conclusion. They're a very safe drug overall, but there are some uncommon side effects, and so some patients can paradoxically get worsening of diarrhea, others can get headache, nausea, rash, and rarely you can get interstitial nephritis or nephritic syndrome, and this is why the BNF says that you have to monitor euthanasia of patients on mesalazine medications. So they don't work in everyone, however, and we need some other options, and so azathioprine or 6-mercaptopurine, the 5 purines, are our next go-to drug. And these are really steroid-sparing agents. They're used in patients who are intolerant of steroids, in those who've needed more than 2 courses of steroids a year, have relapsed once the dose of prednisolone has come down, or the disease has relapsed quickly within a few weeks of stopping the steroids. Now, they work slowly. They take at least 6 weeks to work, and they're probably 12 weeks at least for their full effect to come on board. Because they're an immunosuppressant, they've got more adverse reactions. Some patients can have flu-like symptoms, some GI upset. We can damp the immune system down too much, giving them leukopenia. We can cause some inflammation of the liver, causing a hepatitis. We can cause pancreatitis, rash and infections. And therefore they do need regular monitoring of blood tests. And also they increase your risk of developing skin cancer. So we do need to counsel patients going onto these medicines to use high-factor sun creams, even in the UK, and even if they're just going out for a short period of time in the sun. But they seem to be effective and safe in the long term. Now, mercaptopurine is the active metabolite of azathioprine, and it's often tolerated in those patients who can't tolerate azathioprine. But as we've said, this takes a number of weeks to work, so in those patients who are not getting better with steroids and from their acute flare, we need some other options as well. And cyclosporin is a very old drug, but fits this bill quite well. It's a calcineurin inhibitor, and it's used as salvage therapy in patients with severe refractory colitis. It's got a very rapid onset of action, and initially we give it intravenously and then orally once they're getting better. And short term it will decrease the colectomy rate by about 50%, but its use is limited due to toxicity and long-term failure rates, and therefore its main role is in those patients who aren't already on azathioprine or are on a low dose of azathioprine and bridging them to azathioprine becoming effective. As I've said, it decreases the colectomy rate by about 50%, and so whenever we're going on to salvage therapy, and we would always get the colorectal surgeons to come and see the patients to talk to them about colectomy, because we know about half of those patients are going to go on and need a colectomy during that hospital admission. We do also have newer drugs as well, so the biologics, and these have got an increasing role, and this is in acute severe colitis if cyclosporin is not appropriate, and there is also a maintenance role for biologics now, and so I think their role is becoming greater, and I suspect it's a little bit of watch this space in terms of it becoming more often. So we've talked already about proximal constipation and the need to clear proximal constipation in those patients in which it's present in order to allow that left-sided colitis to improve. We've said that colonic motility is affected by inflammation with rapid transit occurring through the inflamed colon, and in left-sided disease that distal transit is very rapid but proximal transit is slowed to try and be a protective mechanism, but that can result in proximal constipation, and use of laxatives to relieve that proximal constipation may help induce remission in left-sided disease. Now patients think you're a little bit crazy saying that you are going to give them laxatives when they're already going to the toilet multiple times a day, so being able to show them that x-ray that shows that proximal constipation is quite helpful. So we also have to talk a little bit about surgical treatment, and surgical treatment really has two main areas, the emergency surgery and elective surgery. So in emergency surgery, these are in patients who've got toxic megacolon or an acute colitis that's not responding to medical therapy. Elective surgery historically was in patients who are steroid dependent, but that's probably a much smaller indication now as we get more and more drugs that we can use. Patient choice. Patients have just got fed up of having colitis. They don't want to be on medication anymore. They just want their colon gone and their colitis gone with it. And the other indication is those patients that during screening we've picked up high-grade dysplasia or cancer. Obviously when we find dysplasia, we're doing a colectomy to prevent them developing a cancer. So when you are having an operation, it involves a near total colectomy with the formation of an ileostomy, and that stoma may be permanent, or particularly in younger patients it can be rejoined at a later date with something called pouch surgery, and this is where you're essentially using some of the small bowel to form an artificial rectum to get rid of the stoma and give them bowel continuity back. Now pouch surgery comes with its problems, and you may still open your bowels 6 times a day with a pouch surgery, so it isn't for everyone, and there are a number of patients who actually get quite used to having their ileostomy and feel it gives them their life back, and they therefore decide not to go ahead with pouch surgery. The things on the right here are all things that can predict the likelihood of colectomy being needed, and we never would be putting someone forward for surgery based on these alone, but you can imagine, you can work out from these, if you've got over 12 stools on day 2 of treatment, then that means you've got bad colitis. Equally, if your CRP is still up or your albumin is dropping despite treatment, then again you've got bad disease, and so surgery is more likely to be needed. So we'll try and bring all of this together in a case, and this is someone that I saw quite a few years ago now, and he came in, he was a 26-year-old chap, normally very fit and well, and he presented to hospital with a 2-week history of bloody diarrhoea. Now his frequency was very difficult to assess, and no matter what we did to get an accurate answer of how many times he was going to the toilet was almost impossible, and this continued throughout his hospital stay. This included giving him his stool chart to fill in himself, but it was very, very difficult to assess. Prior to admission to hospital, his GP had given him codeine, loperamide and diaurolite, and the codeine and loperamide were to try and slow the stools down. Now, I think that's really probably not a good treatment to try in someone who's got bloody diarrhoea. The presence of blood in the diarrhoea suggests that there's colonic inflammation going on, and if you give those medications, you're more likely to cause slowing down of the stool, but therefore a dilatation of the bowel and potentially megacolon. When we're taking his history, no one else had been unwell. There was nothing to suggest an infective cause particularly, and he'd just been feeling generally tired and lethargic. The reason he actually came to hospital was because his GP had done some blood tests and found his CRP to be very raised and sent him to ED based on the blood tests rather than his symptoms. So those blood tests showed actually his CRP was very high, it's 296, and this is really very, very high for someone with inflammatory bowel disease. So made us think at the beginning whether this could be infective or even whether he could have had a complication of colitis. His haemoglobin was normal, his white cells were up a little bit, and his platelets were also raised as well. His abdominal x-ray showed some inflammation in the left colon and some proximal constipation. On flexible sigmoidoscopy, there was very severe inflammation in the rectum and the distal sigmoid, and the endoscopist doing this therefore didn't progress any further due to the risk of causing a perforation. He was started on intravenous hydrocortisone, and his CRP was improving and his bowels were decreasing. In Leicester now, we would also give a prophylactic metronidazole whilst we're waiting for the stool cultures to come back, and because of the fact that we've had a few cases of entamoeba mimicking ulcerative colitis recently. As he seemed to be improving, although the frequency was still very difficult to assess, he was switched over to oral steroids and he was started on Pentasa, which is one of the mesalazine medications. He was given some laxatives to clear out that proximal constipation as well, and 2 days later he seemed to be starting to flare up again. He was put back on intravenous steroids, and after a further 5 days of IV steroids, his CRP was climbing, he was getting more blood, and he had a repeat flexible sigmoidoscopy that showed ongoing very severe colitis. Now at this point we elected to start intravenous cyclosporin as our rescue therapy, and he was seen by the surgeons, and we didn't have very high hopes for this really, because we were already a number of days into his course of treatment without being any better. But actually he responded nicely to intravenous cyclosporin, and slowly things started to settle down. And he was discharged home on steroids, cyclosporin, azathioprine, Septrin. Now we decided to start azathioprine because of the severity of this first presentation, and we wanted to keep that inflammation damped down. Septrin is an antibiotic, and that was given because he was on triple immunosuppression with steroids, cyclosporin and azathioprine. So over time his azathioprine dose was optimised. He gradually was weaned off the steroids and off the cyclosporin, and to date he remains well, having had a couple of short-lived flare-ups that have settled down, and some years down the line he's managed to keep hold of his colon and hasn't needed to have any operations. So hopefully that was a case just to try and bring together all of the information we were talking about at the beginning. Now obviously normally we'd be able to answer any questions in person, but as this is virtually we can't do that. But you will have the opportunity to ask questions both during your week of the clinicians that you're working with, and also in that case presentation and feedback session that you'll have with me towards the end of your gastroenterology week. So I hope this has been useful today, and I look forward to seeing you all in person.